I think that we're going to keep going and actually now move above the neck. So from what is in the program, we're going to switch orders and go to the sort of the more basic before we go to neuroperfusion and start with the equivalent of what's a good body CT scan. We'll do it in the head. What's a good neuro CT scan? And Dr. Gupta is going to present for us. Thank you.
Thank you, Cynthia. Good afternoon. For the next half hour or so, I'll be talking about what constitutes a good neuro CT. And here's the overall outline that I'm going to be following. I'll talk about first what we need to see in a good head CT exam. I'll go over some of the protocol issues and some dose optimization strategies, and then I'll talk about some newer tricks using dual energy CT. Okay. So let's just start with a simple slice from a head CT. Where is the abnormality? This is something that you may routinely come across when you're practicing in the ED, and you will notice that maybe there is some loss of you see the cortical ribbon everywhere, but in this area there is a cortical ribbon on this side, but not on this side. So perhaps there is an abnormality there. So a CTA was done, and there is a cutoff of the ACA. This artery is missing, and on the CT source images, you can see that there is a perfusion deficit on this side, while the cortical ribbon is maintained on that side. Okay, the DWI image shows clearly where the defect is, but you ought to be able to pick that up on the non-contrast head CT. So we reached this stage only because somebody called that into question right in the beginning. So you need to have good gray-white differentiation in your images in order to be able to see these subtle changes. And so we're talking about Hounsfield units of maybe about 20 to 30 Hounsfield unit differences is something you ought to be able to pick up. Okay. Here's another head CT, young patient after trauma. Most people will pick out that there is a subdural over here. Many first-year residents would miss the fact that there is a large amount of hemorrhage on this side also, which is isodense with the cortex of the brain. So these sulci, they don't go all the way to the cortical margin. There is a gap between them. That means there is there is subdural hemorrhage on both sides of this brain. Okay, and we ought to be able to pick that out. Okay, so you need proper cupping correction. Very often, if the cupping correction is not done properly, right underneath the calvarium, you'll have the shadowing which will confuse this artery. Okay, a pediatric patient, the chest CT was done. Somebody called into question this retropharyngeal soft tissue. A CT scan was done. Again, there is subtle hypoattenuation in this area. There was to the oropharynx there was a drumstick injury. Maybe you can see that there is some defect here as well. A lower slice showed you an air focus within that area. So there is a full-blown abscess over here. Okay, you ought to be able to pick that up. You ought to be able to tell the surgeons where the track is, where the drumstick actually entered to cause this abscess. Okay, so the diagnosis was made because the scanner was properly calibrated, and we have the proper soft tissue discrimination that is needed for all these exams. Okay, there's another scanned routine trauma head. A 44-year-old fell from a tree. You ask the question, what was a 44-year-old doing in the tree? but you don't stop to ask that question. You just sort of look at the images. Say, well, there is some air in the globe over here. Maybe there is some proptosis over here. Even though air was called, a fracture in the orbital bones was not found. Okay, and nobody really this was actually a miss. And 2 months later, the patient comes in, the eye is still swollen, there's a lot of soft tissue stranding over here, there's a lot of contrast enhancement. The patient went to OR, this was taken out. Okay. Therein lies the importance of having proper. And there's another pencil versus globe. You can see actually it doesn't project very well, but you can see that the wood is hypodense, but it's not as hypodense as air. Okay, you rely on that subtle difference. Wood is mostly air, that's why it floats in water, but it should be a little bit more dense than air. Okay, and you can see the fact that this pencil has gone through the globe into the brain. Okay. So you need accurate, reliable Hounsfield calibration. This is a little bit subtle to see. This patient came in, had some kind of trauma, I forget what. There was some soft tissue swelling noted here, and there is a subtle line through here. I tried all sorts of different kernels and so on. Unless you use very thin slices and a sharp kernel, you won't see this fracture. Okay. So you need high spatial resolution and good modulation transfer function. Okay. This is another miss, a 4-year-old girl with 2-week history of headaches, abdominal pain, anorexia and vomiting, was put on antibiotics because they thought she has sinusitis. This is a clean slice, something you'll expect. A lot of, in the posterior fossa, there are some streak artifacts, something you expect. Over here, this was thought to be just beam hardening. Okay. Nobody stopped to think that, well, on this side, the cavernous sinus is nice and convex, but over here, there's some soft tissue. Okay. And the same thing over here. The patient was sent back. A week later, the patient came back. More imaging was done. Now you see a soft tissue enhancing mass over here. More imaging was done. You see this tumor has actually eaten through the bone. MRI shows a large tumor. The tumor is there in the clivus. And this turned out to be Burkitt's lymphoma, very fast-growing lymphoma. Okay. So you need artifact-free posterior fossa and skull-based imaging in order to do good neuroimaging. Okay. So to me, a Neuro CT is the chest X-ray of the brain today. Okay, it is done very routinely. We go through like hundreds of these in a day. They're all the scanners are busy, basically cranking out these things, especially at night when there's all these traumas are coming in, and it must support quick, confident read. Okay, if the scanner is not working properly, if the protocols are not right, you will miss things, and bad things always declare themselves. They'll come back to bite you. Okay, and the main culprits are poor signal-to-noise ratio, poor contrast-to-noise ratio. The kernels are not properly set, or the right protocol is not used, and there are a whole bunch of artifacts that one should be aware of while examining this. Motion is one of them. Reconstruction algorithms assume a stationary object. Obviously, in pediatrics, that's rarely achieved, and the only solution there is have faster and faster scanners, and there are scanners better than this available. There's a recent development that we have been using a lot, actually, which is the flash scanner, which is very high pitch scanner. You scan at 3.2, a pitch of about 3.2, and you can do entire chest in about a second, or entire chest, abdomen, and pelvis in about 2 seconds. Very low dose, very fast scanning. And you can really catch the peak of the bolus that way. And there's a cardiac version of that we use a lot. So we are getting these sub-second cardiac scans with sub-millisievert dosing. So I think that's a very significant advance as far as artifact reduction and motion reduction is concerned. Scatter is another big problem. It happens wherever there is beam hardening. The scatter problem and the beam hardening sort of exist in the same place where you are somewhat photon starved. People don't realize scatter is a huge problem. Unless you have source side scatter rejection, you can have as much as 60% of the number of photons coming in could be coming in from scatter. So that's a major problem. Beam hardening, as everybody knows in this crowd, can be a major problem. You get all these artifacts because of the beam hardening. Over here, there is actually, it looks like air, but there is obviously soft tissue. It has been sort of attenuated out because we have petrous ridges over here. So if you took a cylinder of water, you'll get this cupping effect to the cylinder of water, and everybody. So you have to do cupping correction. Ordinarily, you will just pass this scan as having nothing, but there's a little bit more hypoattenuation here. if you give contrast, you see that there is a rim enhancing lesion over there. Windmill artifact, if I play it a few times, you'll start seizing or something. Everybody has seen this artifact. The reason is you're not capturing the dense object in all the projections. This thing will go away if you change it to axial scanning. And one way of getting rid of this windmill artifact would be to overlap your helical slices, use minimal possible table feed, maximal possible gantry rotation, and use thicker slices. Essentially, as the finer your helix, less would be the artifact. Essentially, more you bring it closer to an axial scanning mode, better it would be. Okay. I don't want to go through this is one of our sample protocols for standard routine non-contrast head CT. We do all our examination in helical mode, 120 kV, 250 mA, a pitch of about 0.5, slice thickness of 1.25 with an interval of 0.625. That is pretty standard. What should be noted here is that we recon from that a 5 millimeter thick standard slice, and then we also output axial slice in using a bone kernel, using a sharp kernel. And we always make coronal images. It was pointed out earlier, there are things that you see on coronal that you would see on the axial, but they are much more better seen on the coronal images. Okay. So here are some dose reduction strategies. Use another modality if you have to. That's the best strategy sometimes in pediatric imaging. Optimize your acquisition. Your acquisition should be tailored to your clinical need. So if you're doing a sinus CT, you don't really need to do a routine head CT. You can do a very low MA scan. Okay, you can optimize your reconstruction using post-processing. There are iterative recon techniques available that can really lower the dose. And you should optimize your readout, coronal reformats using proper window level and so on are important. Okay, so use the lowest possible MAs proportional to the degree of intrinsic tissue contrast and acceptable level of noise. So as I said, for example, for doing a sinus CT, you don't really need a high MA. Even as low as 30 MAs is sufficient. Okay. Also, when the MA is reduced by a factor of half, the image quality goes down by a factor of about square root of 2. So most things are still perceivable even at low dose. There was a study that was done at our institution where on most head CTs, if you reduce the dose by 50%, you really would not miss much. Okay. So many of these things have been emphasized before, so I'll go through them fast. Lower kV obviously increases the photoelectric effect and increases the conspicuity of the iodine in the scan. So it is very useful for doing perfusion imaging, which is something we'll be talking about. Adaptive dose modulation has been talked about, so I won't say much. There are many things which are actually non-technical. Looking at the record saying, have these exams been done before? Things like that, they count a lot. So decreasing motion, moving all these dense objects from the field, optimizing contrast bolus, doing it at the right time, things like that. All those things count a lot. Okay. Adaptive dose modulation was already covered. There is dose modulation both in X and Y dimensions, and it can substantially decrease your dose. There are these newer techniques that have come out, which are GE calls them Acer, Siemens calls them Iris. All they're doing is they're going beyond the filtered back projection, and they're doing essentially iterative reconstruction so as to minimize noise. So here's your normal image, and this is the image after iterative reconstruction. Okay. And if you use, in one of the scanners, here is some data, you can really substantially reduce the dose almost by a factor of half if you were to use iterative reconstruction techniques. Okay. There are how am I doing on time? There's no timer here, so I'm just sort of, I'm good? Okay. So I've been using dual energy scanner for almost 2 years on the dual source scanner that we have. GE has also introduced a new scanner called discovery, which has dual energy capabilities. And I find that there are applications where dual energy can actually help you a lot. Okay, a single energy scanner will give you a single Hounsfield unit number, and all the discrimination is based on morphological information, prior information. The CT number doesn't really have the information about what tissue is what. It is enabled to distinguish, for example, blood versus dilute contrast. Hemorrhage is bright as well as contrast is bright. There is blood versus diffuse mineralization. Many times you get this non-contrast head CT after trauma, and there is this hyperdensity, and the question is that a little bit of hemorrhage, or is there some diffuse mineralization within the brain parenchyma? Uric acid versus calcium oxalate, it doesn't happen typically in brain, but in renal stone and in gout applications you may have something like this. Similarly, in gouty tophus, you may be able to use dual energy CT scan. And the principles were already covered. Different tissues, different materials behave differently as the energy of the beam is changed. And even though we are using polychromatic energy beams, if you separate the mean energy enough, let's say go from 80 kV to 140 kV, you get enough of this difference in behavior. Iodine, for example, drops very fast. Soft tissue stays pretty much horizontal. And you can use that differential attenuation to figure out what object is what. And essentially what you're using is how much of the total Hounsfield attenuation that you're getting is coming from the photoelectric effect and how much of it is coming from Compton effect. So those are the two underlying processes that you decompose your pixel into, and then use that to determine what is that pixel consisting of. Just about all vendors are active in this field. I put only 2 up here, but I know Toshiba is also working in the same in this area. Siemens has a dual source CT where you have 2 X-ray tubes and 2 detectors, and then you sort of spin them faster and acquire the images simultaneously, but at 2 different tube energies. So you'll operate one tube at 80 kV, the other tube at 140 kV, and you acquire your set of images. So you'll get 2 sets of images, one at 80 kV, another at 40 kV, and then you can do post-processing to do material characterization. GE has a slightly different approach where you do fast switching of kV, where you pulse the tube from 40 kV to 80 kV to 140 kV and back, and you acquire very fast images which are interleaved. So essentially you are doing dual energy at the projection level. Okay. And here are some of the pros and cons. You're doing simultaneous acquisition in the dual source scanners. You can optimize the tube current for each one of them. Okay, so the 80 kV tube and the 140 kV tube can operate at 2 different tube currents, and those can be modulated. If you are doing fast kV switching, then you are doing voltage modulation. You cannot simultaneously be doing tube current modulation. So you lose out a little bit on the dose because of that. These projections are 90 degrees apart. That means they're not essentially simultaneous. So you do not have projection level dual energy scanning when you're doing the dual source, while you can do that over here. So these are some of the pluses and minuses of these two. Okay, and if you have dual energy, irrespective of what is the underlying engineering of the device, the physics doesn't change. Okay, so you can do pretty much the same sort of things no matter which scanner you're using. For example, you can do bone subtraction here, and you can see, for example, the iodinated contrast within the vessels. You can take out all the calcified plaque from the aorta, and you can have this essentially non-calcified portion of the aorta. You can do plaque analysis. In kidney stones, you can distinguish between calcium oxalate stone and uric acid stones. Okay. In gout, for example, you can show where the gouty tophi are. And all that is that material discrimination is possible because of this. Okay. You can do, for example, ultra low dose spectral CT. It was already mentioned. The conspicuity of iodine increases as you lower the tube voltage. You can even make it further conspicuous by using dual energy CT. So with very low amount of contrast on board, you can do very good angiographic imaging. You can also subtract out beam hardening artifact as is shown over here. Over here, for example, this is the 100 keV image, and you can see very few beam hardening artifacts in the posterior fossa. Okay. So where is the killer app for this particular modality? Most of these things are nice to have. Okay. Where is the must-have aspect of dual energy? Okay. So I'll show you an example and a class of patients where it is now our current clinical practice that we scan all these patients in dual energy. Okay. So here was a young patient came in with acute left hemiparesis. MRI showed there's an infarct. There was a clot in the M1 segment. The patient was taken for embolectomy. The clot was taken out, and then we did a post-procedural CT. Okay. Here is the pre-procedure CT. You can see a dense MCA sign. Maybe you can recognize there is some subtle loss of gray-white differentiation here. There was an infarct here. The patient had a stroke, and the embolus was taken out from the M1. When we did the post-procedure CT, we saw this. And there was a stent also placed in the carotid. Now the question is this hyperdensity on the single energy hemorrhagic conversion of the infarct, or is it staining of contrast? Okay, and that's a very important question because there's a stent now in place. You want to anticoagulate this patient. But if there's hemorrhagic conversion, you don't want to anticoagulate this patient. Okay. So we did a dual energy CT on this. Here is the 80 kV image. The hyperdensity is a little bit brighter, as you would expect. This is 140. It's a little bit more lucent because the energy is higher. You separate out what is what. You get an iodine overlay image and a virtual non-contrast image. And what you see here is all the hyperdensity is on the iodine overlay image, and all you see is a little bit of a hypoattenuation on the virtual non-contrast image. So what that proves to me is that this was completely contrast staining, and there was no hemorrhagic conversion of the infarct. Okay, so we have done a set of patients here where we have measured the sensitivity and specificity of dual energy scanning, and it's almost 100%. With nearly 100% confidence, we can distinguish hemorrhage from iodinated contrast staining. Okay. So just to conclude, here are some take-home points. A routine head CT. The ACR recommendation, I believe, is 75 or 100 CTDI. Volume is 7500 milligray. You can do it well below that and be diagnostic. Okay, one has to configure the protocol to the clinical need. As I mentioned, for trauma CT, you generate different set of images than for a routine head CT. One should avoid orbits if possible. However, there are times when orbits should be included because that's where the pathology could be there. Okay, don't sacrifice diagnostic quality because you are so focused on the dose. As somebody already mentioned, the biggest wasted dose is the dose coming from a non-diagnostic examination. In pediatrics, one can reduce the dose substantially by lowering the KV, and you can essentially reduce it by a factor of 50% very easily. And screen with low-dose CT and confirm with the MRI if that's a paradigm that can be followed for the pathology in question. That should be done for all pediatric patients. And also for pediatric patients, we have found the high-pitch scanning using dual source to be very, very efficient because you can scan it very, very fast. Okay, avoid axial versus helical. Time was thought to be a parameter there. Right now, that is no longer the issue. The axial scans are pretty much as fast as the helical scans are. Artifact profile is different, and some of the other things are different. With the helical scan, you can get arbitrary recon interval and things of that sort. You cannot do that with axial scanning. With axial scanning, you don't get any windmill artifacts, so there are pluses and minuses. And there are people who scan posterior fossa differently from the supratentorial brain because of those features. Okay, dual energy CT is a new tool and it's very good for material discrimination, especially when you're discriminating iodine from other dense objects. Okay, and it's a quantitative tool, and I see more applications of this coming up in perfusion CT, and, which is something we'll be talking about. So with that, I'll stop. If there are any questions, I'll take those questions.
While we answer some questions, so maybe if you're over here.
Sure.
Yes, please.
I'll repeat the question if you can just speak loudly.
During our recent application for implementation of adaptive ear reconstruction, we were advised that many neuroradiologists do not tolerate the typical levels of 30 to 40% of ACER for head CTs, and we implemented 20% of ACER, and then were asked by our neuroradiology section to reduce that because they were unhappy with the effects on the image quality. But I saw that in your talk that you had used 30%. Is that something which is universally accepted within your neuroradiology section, using that level of adaptive statistical iterative reconstruction?
Actually, there is no standardization with respect to that. We have only one scanner that is capable of doing this. All other scanners are not capable of doing this. And as far as the use of ACER is concerned, we have tried with 30%, but sometimes you can get over smoothing, and some of the look of the image can change and can be bothersome to some radiologists. I don't have a good answer to that question. The numbers that I mentioned were with 30%, but that is not our standard protocol.
Do you use it at all on your head CTs, do you know?
We've used it on research basis. We've not really used it on a routine basis.
Thank you.
Thank you. Excellent talk. I wanted to clarify the pediatric imaging recommendation you made on that last slide. It said use half MAS on pediatric patients. Are you, in the neuro setting, what do you define as a pediatric patient? Is that an age cutoff of, developmentally, is the skull... where do you kind of cut off
So it's pediatric is a wide age range, actually, and that was sort of a recommendation really more for everybody under 18 years of age is pediatric, but then there are these pediatric patients who are much bigger than me. So obviously you would not use that. For head, it actually matters less, and we're doing more and more MRI scanning for head CT. So it's only really more for trauma imaging that we use head CT, and there we are really looking for two things. We are looking for hemorrhage with intracranial hemorrhage, and we're looking for fractures within the calvarium, and there you can actually reduce the MAS to half the value without losing.
Okay, and going all the way down to infants, are you at lower kVp anywhere? Are you keeping the same?
I actually do not know the answer to that. I'm not a pediatric neuroradiologist. We have a separate division that
okay, thank you.
We consult for a very large facility that will not consider helical scanning for routine head protocol because they refuse to scan through the lens of the eye. I'm just curious your thoughts.
The idea of cumulative dose to the lens has been known for some time, and clearly you do want to avoid the eyes, and the best way of avoiding the eyes is to tilt the head so that you're scanning from the skull base up, and the eyes are not there in the field at all. And that's not a helical versus axial imaging question. That is, are you willing to take the time to turn the patient's head and do a scout in a manner that you're avoiding the eyes? At our practice, we are a level 1 trauma center. A good number of our exams are for trauma, and there you have to include the eyes in the field of view.
Minor technical clarification. You were comparing the GE versus the Siemens dual energy capabilities, and you alluded to differences in kV, of course, but the dual source Siemens could do different MAs. I believe that it's true that the GE scanner can't do different MAs, but they can pulse modulate and do different times, so they can deliver a different dose to the 80 kV than the 140, and therefore getting the same effect.
The overall dose, and this is just sort of my practical experience, we have both scanners side by side and we're using them routinely. The dose on the dual energy heads coming from GE is a little bit higher, and we're not using it for that reason.
Hi. Tom Slovis, Children's Hospital of Michigan. Just to help with the neonate and the young infant, we don't do CT scanning at all in that group. There's very few indications for that group for any CTs of the head. They should be all MRs. And I guess I agree with your clarification about your slide said screening of pediatric patients with CT. We don't believe in that. We don't think that in general, if it's all possible, you get them on your MR scanner for most of the complaints, you do MR and you don't screen with CT. But the trauma, you're absolutely 100%, I agree with that. It's the major reason that we do CT in children. Thank you.
Thank you.